إن الله وملائكته يصلون على النبي.
Okay, Assalamu Alaikum. My name is Farrah Hafeez. I am a product of IAGD, so it's wonderful to be here in a different light. You know, usually I'm in the audience and now I'm actually on stage. So it's a pleasure to be here. I want to thank Dr. Junaid Haq for inviting me to be the speaker for tonight. We will be talking about breast cancer screening. So I know it's not the most interesting topic. However, it is Breast Cancer Screening Month, and that's why this is important. So let's keep that in mind as we progress through the lecture. So I know that, you know, with medicine, there can be a lot of medical jargon, a lot of, you know, big terminology. I'm going to try to simplify it and try to avoid that just for simplicity's sake, as well as, you know, for complexity. I'm sure that we don't want to sit here and learn medical facts. So we'll try to make this as seamless as possible. I do like to make this interactive, so please, you know, feel free to ask questions and raise your hand or throw out comments. We don't have a very large crowd today, so it's okay if we are more casual. And then I am working with two screens here, so please bear with me. So let me tell you a little bit about myself. I work at Henry Ford Health System. I am currently in family medicine, so I do outpatient medicine. I am also certified in obesity medicine. So what I do is I take care of patients that are overweight and are going through bariatric surgery, and I deal with patients pre-operative, so before their surgery, and then I deal with them after surgery and deal with post-operative weight regain. And then lastly, I also do some teaching on the side for Michigan State University. So I kind of do many different things. It keeps me interested. So let's talk about today's objectives. So I want to talk to you about the disease burden. So basically, why is breast cancer a big deal? Okay, we'll be talking about the risk factors, signs and symptoms, preventative medicine. So this is really important, you know, why we practice preventative medicine. So this is what I tell patients very often when they are refusing, let's say, their mammograms, their colonoscopies, even their prostate cancer screening. Oh,
better.
Oh, is this better? Okay. Can you put that in for me?
Okay.
Do I just peel it open like this? Oop.
Is it good?
No, you do it for me. So a lot of patients refuse screening tests. And what I tell patients is that we are so lucky to be in the United States where we practice preventative medicine. So what does that mean, right? So prevention means to prevent a disease from occurring. And in other countries, you know, let's say India, Pakistan, for example, they don't practice preventative medicine. So there is no universal recommendation that everybody across the board has to get a colonoscopy. So what ends up happening? That patients get sick, they start having, let's say, blood in their stool, and then they go to the doctor and the doctor says, I'm so sorry, you have stage 4 colon cancer and there's nothing we can do. That is what happens in other countries. We are so blessed to be in a place that practices preventative medicine. And what that means is that we do screening to prevent disease. So keep that in mind when you yourselves or other family members refuse their screening test. It's there to save lives. So we're gonna kind of get into that a bit further. We'll be talking about the breast cancer screening and then the recommendations. So again, I'm trying to make this as seamless as possible. So I have this figure over here, and as you can see, I have males included as well as females. And so this is recent data from 2020. So what this shows is that out of all cancers, men are most likely to get prostate cancer, lung, and bronchus, most likely from smoking, right? And then colon and rectal cancer. So out of all cancers, about 46% are those three types of cancers: prostate, lung, and colorectal. It's important to note that we screen for all of these things. So who knows? How do we screen for prostate cancer? And I'm gonna look over here because women don't have a prostate. How do we screen for prostate cancer? Has anyone had that done before? That's colon cancer, so you are close. With prostate, we screen for prostate cancer with blood work. So your doctor will probably order a PSA, which is blood work, to see if that is elevated. So that's one way. So how about lung? So you mentioned lung. We do lung cancer screening with what? A low dose CAT scan. That is a recommendation, and that's a universal recommendation. And then colonoscopy. Yes.
Are there any symptoms for lung cancer?
Absolutely. Yep. So for prostate, males are going to have issues with urination, stop and go stream. There may be blood in the urine. So remember, and that's a really good point. If you start to have symptoms, it's no longer screening, it's diagnosis. You only screen when the patient is asymptomatic, which means what? They have no symptoms. So if you wait to the point that you start having symptoms, it is no longer a screening test. It is automatically a diagnostic test. And that's important for insurance purposes. Why? Is because under Obamacare, all screening is covered. 100%. There is no cost sharing, okay? But once you start having symptoms, it's no longer covered. Your co-pays apply. So that's why it's important to take advantage of the screening. And again, screening is when you have no symptoms. None at all. That is the difference. And we'll get into that a little bit later. And then so going to colon and rectal, we screen for that with a colonoscopy, okay? Notice that breast cancer is not on this list for men, okay? So out of all cases of breast cancer, 1% tends to be males. So it can still happen, but it's very, very low, okay? So out of 100 people, 99 will be women, that one will be a male. And I've seen patients that have had breast cancer that are male. And if you do get breast cancer as a male, it tends to be very aggressive because it's not very common. Now let's flip that over and take a look at females. So what is number one for females? I don't know if you can see this. Oh, you really can't see them very well. I apologize. So the number one for female is breast cancer. Okay, so looking at the numbers, 30% of all cancers is breast cancer in women. For lung and bronchus, it's 13%, and then colon and rectum, it's 8%. So breast cancer is number one. And then looking at the estimated deaths, for female, breast cancer is number 2 on that list. Lung cancer is considered number 1, and most likely because of smoking, right? I mean, unfortunately, people still smoke, and I'm assuming that as the rates of smoking decrease, that should reverse. So we probably will see less deaths from lung cancer and more deaths from breast cancer. So I just wanted to kind of show you the disease burden, why this is important, and what we can do about it. All right, so let's take a look at some of the risk factors. So who can shout out some potential risk factors for breast cancer? Just take a stab at it. What do you think? Anything? Okay, so let me just go through them then. So first of all is if you're female, right? Because as I said, females are more inclined to get breast cancer. So if you are a female, automatically that's a risk factor. Number 2 is your age. So we tend to see breast cancer in older women. We can still see it in younger women, but it's more likely in the older population. Genetics. So there are certain types of breast cancer that are linked with a gene, and that's the BRCA1 and BRCA2. If you go see your doctor and you tell them your family history, and if they are concerned that there could be a high risk for breast cancer, they can actually order the genetic screening test, and it may or may not be covered by insurance. So that's, that's another topic on its own. But there are breast cancers that are linked with your genes. And that can be kind of problematic because if you do test positive for a gene, that may have some implications for your work environment, for example. So would your employer want to hire you if they know that you will potentially get breast cancer and that you're at a higher risk? They may not want to hire you. Or if you are applying, let's say, for life insurance, for example, you may not qualify for life insurance if you are positive for a genetic mutation, because again, you're more likely to get breast cancer. On the flip side, if it's negative, so your genetic mutation, so you do not have a genetic mutation, you can still get breast cancer. You can't get a false sense of security. The reproductive history is important. So women that start their menstrual cycle early and women that end their menstrual cycle late. So women that have menopause late, they are exposed to hormones for a longer period of time. And the more that you're exposed to hormones, the more the cells grow and grow and grow, and you are at a higher risk of cancer. Having dense breast. So we'll see some images of this shortly. But if you have dense breast, you may have a mass, but it's obscured by the density. So when you do a mammogram, which is just an X-ray, the X-ray beam cannot go through the density, and so therefore you may miss it. Personal history of breast cancer. So if you've been diagnosed with breast cancer, you can have breast cancer again. Pretty simple there. Family history is very important. So when you go to the doctor, please tell them what your family history is. If you don't know what the family history is, find out before you go. If your parents are still alive, call them up, ask them what conditions do you have? What conditions do Dadi and Dada have? Really understand your family history, because that has implications for you as a patient. So if there is a family member that's first degree that has breast cancer, then you are more likely to get breast cancer. So what do I mean by first degree? First degree means, for example, like my mother would be a first degree relative, my sister would be a first degree relative, and my daughter or my son would be a first degree relative, okay? So if they, God forbid, have had breast cancer in the past, the recommendation is that I should get screening done 10 years prior. So let's say that I had, God forbid, a first degree relative that was diagnosed with breast cancer at the age of 39, I would start getting mammograms at what? 29, okay? So again, it's important to know your family history, and then if there's a previous treatment using a radiation therapy to the chest. All right. So these are all non-modifiable factors. So what that means is that no one can change your gender, no one can change your age. Even with your family, you can't change your family, even though you may want to, but you can't. So there are other risk factors that are modifiable. So who can throw out some modifiable risk factors? And what that means is things that we can do to decrease our risk of breast cancer. What do you think? Just throw out some. What was that? Okay, so mammogram, yep, and we'll talk about that. But what I'm referring to is things that we can do to decrease our risk. So one is not being physically active. Be physically active. That will decrease your risk of getting breast cancer and cancer in general, not specific to breast cancer. Being overweight or obese, especially after menopause. So when a woman starts or stops her menstrual cycle. And why is this so? That's because fatty tissue produces what? Hormones. Fatty tissue produces estrogen. And the longer that a person is exposed to estrogen, what? Remember what I said before? The cells proliferate and you can get a cancer. Taking hormones, so there's certain subset of the population that may go on, let's say, hormone replacement treatment. They are at an increased risk. And then drugs. So smoking does what? Increases inflammation. So if you're a smoker, please stop smoking. And then of course, drinking alcohol. Same thing, it increases inflammation. All right, so we're gonna talk about the signs and symptoms of breast cancer, and I'm gonna show you some pictures, and we're gonna talk about signs of breast cancer using lemons. So let's talk about some lemons, okay? All right, so now we have a wonderful picture of some lemons. And let's talk about the first one. So the first one is if you see a hard lump, okay? So in the breast, you have many different anatomy in there. So one is you have milk lobes, right? And if you're doing a self-breast exam, and you can always go online and type in how to do a self-breast exam, and you'll have all these videos on how to do it. But if you're feeling, and if you feel a soft pea, like a little green, you know, one of those green peas, that could be a milk lobe. And that's absolutely normal, nothing to worry about. If you feel a little kidney bean, you know, one of those maroon kidney beans, it's soft, it's movable, it's not tender, that is probably a lymph node. Not concerning. It can be concerning if it changes, if it grows. You just have to monitor. But if you have a hard lump, okay, that is immovable, so you try to move it and you just can't move it, it's stuck. It's hard, it's tender. That is not good. So in terms of lemon, if you feel a lemon seed, that is not good, okay? So the first one is a lemon seed that can present as a hard lump. 2 is a thickened area. So you can get thickness in your breast from many different things, breastfeeding, if you're in a certain cycle, you know, in terms of your menstrual cycle. But those should go away. Now, if you have a thickened area in your breast that is not changing, it's thick, that can be concern because there could be cancer cells that may be blocking circulation, and therefore that area becomes very thick. Or there could be a tumor that's growing near the surface of the breast, and that presents with thickening of the skin. All right, what is this? This is a dimple, okay? So God forbid if you find that you have a dimple in your breast, that could mean that there's a tumor deep in the breast, and that's pulling the skin towards the back. So it presents with an indentation. That is not good. And how you can see that is if you just lift your arms up, you can actually see that the whole breast skin doesn't move uniformly. So that's how you would actually diagnose that dimple. Okay, a nipple crust. So this can be seen with a condition called Paget's disease, and I don't want to get into specifics here. But when cancer cells spread inside the breast, it can actually go into the nipple as well. And it can create a scab on the nipple that can be very sore and tender, and it doesn't go away. This is not good. All right, next is unexpected fluid. So you can have discharge. Some discharge is normal. So if you're breastfeeding, for example, that's normal. But you can have discharge in other cases as well. For example, if there's infection, if there's a cyst there, But if the discharge is bloody, this is not good. And I did have a lady that came to the clinic. She said that she was just taking off her undergarments and she noticed a spot of blood and thought that it was important enough to come and see me. Well, I did a breast exam and I was able to express blood from her nipple. I said, this is not good. We sent her for a diagnostic mammogram, not a screening mammogram, because now she's having symptoms, and she indeed did have breast cancer. So, it's something to definitely watch out for. If the breast is red or hot, this could be an infection, okay? It could be a rash, it could be eczema, or it could be of concern. So cancer can block the flow of lymph, which is how your body gets rid of the waste products, and that can cause swelling in that area and redness. But it typically does not present with a lump. All right, a bump is the next one. So realize that not all lumps are cancerous. They can be benign as well. You can have a cyst. Who knows what a cyst is? Anybody? A cyst is just a fluid-filled sac. It's benign, just a little ball of fluid. So that can present as a lump. Or you could have benign lumps. The most common is a fibroadenoma, again, a fancy term, but it's basically a lump that is not cancerous, and it's just a collection of normal tissue. So if you find a lump in your breast, the best way to determine what the cause is to do a biopsy. So most likely, if there's a lump, you're probably going to have further workup done. Skin sores. So realize that breast cancer can sometimes build up to the point that it breaks down the skin, and it can show up as a wound. So you may have a wound on the breast and it may go away. That's not concerning. With breast cancer, the wound never goes away. It's there. All right, a sunken nipple. So you can have an inverted nipple where it doesn't stick out. It actually is sucked back in, and that may be your normal, and that's okay. However, if you've had normal nipples that extend out, and then one day you kind of notice that, hey, something looks a little bit different here. It's more flattened, or it's turned inward, that could be a sign of a breast tumor underneath that is pulling the nipple inward. Again, not a good sign. A growing vein. So obviously we have veins all over our body. That in itself is not of concern. You can get enlarged veins, for example, if you gain significant weight or if you're breastfeeding. But if the veins are very, very pronounced, so they're very, very big, and they're growing, this could be a sign of cancer. Because guess what? Cancer needs a blood supply, right? If you don't feed a cancer, it's not going to grow. So what happens is that the body starts to form blood vessels to feed the tumor, and then it grows and grows and grows. So if you see growing veins, please get that checked out. And then orange peel. So if you look at an orange peel, you notice that there's little bits of indentation, right? The orange peel is not nice and smooth, right? So this is called kind of like a dimpling of the skin, and this is caused by swelling of the breast, and that causes the hair follicles to look like little dimples, and this could be a sign of an inflammatory breast disorder. Again, it needs to be evaluated. And then lastly is if you have a new shape or size. So realize that everyone's sides are different. So a left breast is different from the right breast. But if you are noticing some changes where it's more than just a change in asymmetry, it's a gross enlargement of one versus the other, Or if one breast flattens, it swells, it droops, and it's more spontaneous, where it just kind of happens all of a sudden and it's not going away. These are all signs to look out for. Okay, so these are all of these signs and symptoms. So it's important for you to know your lemons, okay? And keep all of this in mind. I'm gonna briefly talk about preventative medicine. I did mention it before. And again, I don't wanna pull you down with all this medical jargon, but I think it's important because patients don't understand that we work to prevent disease. I don't just treat disease. I want to prevent disease. So when you see patients that say, well, I only go to the doctor when I'm sick, that is absolutely wrong. You should go to the doctor when you're healthy. Why? It's because it's my job to keep you healthy, right? That is the purpose of prevention. That is the purpose of screening. That is why other countries don't do mammograms, colonoscopies, prostate cancer screening. That is the difference. We were actually in Dubai recently. My whole family went in June, and we had to get a COVID test, in order to travel. So so we went to a local medical center in Dubai to get the COVID screening, and so they had my email on file. And so because it's breast cancer screening month, I got an email, and it said, "Get your mammogram, 300 AED." So basically, in Dubai, they are charging for a mammogram. 300 AED comes out to be about $800. So maybe it's not a huge amount, but I'm pretty sure that there's no lines of people standing, trying to get their mammograms when they have to pay for it. In the United States, mammograms are covered. There is no copay. So get the mammogram. It's there to protect you. And there's different tiers of prevention. So there's primary, there's secondary, and tertiary. Primary is to prevent the onset of disease. So an example of this would be to talk to a patient, let's say, about smoking cessation. Why? Because if we can have a patient quit smoking, we can prevent what? Lung cancer. Another example of a primary prevention would be the COVID vaccine. If you get your COVID vaccine, that can prevent what? COVID, right? So that's an example of primary prevention. Now, mammograms come in secondary prevention. That's to detect the disease. So patients have no symptoms, but we are doing this test to detect potential breast cancer. And then tertiary prevention is when you already have the disease. So for example, patients that are diabetic, what ends up happening? They have to get yearly eye exams, they have to get yearly foot exams, they have to get yearly urine exams. Why? Because we are trying to prevent the complications of diabetes. At that point, you already have the disease, right? So we are past primary prevention, we're past secondary, we're already at tertiary prevention, where you already have the disease, right? The whole point of prevention is to not allow you to even get the disease in the first place. All right, and then just a few points about the characteristics of the disease. Again, I don't want to bog you down with all this medical jargon, but we only screen for a disease that can have a significant impact on the quality or length of life. So if there is a disease that is not very significant in that it's not going to affect your quality of life, it may not result in death, we probably are not going to screen for it. It must be very common, because realize that everything that we do has a cost associated with it, right? That cost may not be sent over to you, because again, all screening is covered by insurances, but regardless, your insurance company is still picking up the tab for a screening test. And so the number of cases should be high enough to justify the cost. And then there should be an effective and acceptable treatment available. So for example, think about, let's say, Alzheimer's. Is there a cure for Alzheimer's disease? There isn't. So do we do screening brain MRIs on everybody? We don't. Why? Because there is no cure for it. We only do screening tests on diseases where there is a cure for it. And with breast cancer, there is a cure. We can save your life, right? So realize that we're doing prevention, we are doing screening on diseases where there's a cure. And then again, there has to be an asymptomatic period. That is important. So if you have no symptoms, that is screening. Once you develop a lump, that is no longer screening. That's diagnosis. You are already far beyond the asymptomatic, which means no symptoms phase. And that cancer may actually be far further along than you think. Okay. Let's go on. Okay, so this is what we just discussed. So screening is to do early cancer detection. It's typically done annually or every 2 years. And then we'll talk about the age as well. All right. And then here is an example of a mammogram. So in essence, a mammogram is just an X-ray. So if you're all afraid of, having testing done, realize it's just an X-ray. It's nothing like a CAT scan. It's nothing like, even an MRI. It's just a simple X-ray. And this is what we see. As you can see, this is labeled. The nipple is here towards the side. The armpit is towards the lateral side. And then the tumor shows up as bright white. Right? That's all it is. It's just an X-ray. Now, there may be some findings that don't show up on an X-ray. So for example, if you have a very small tumor, that may not show up. But then you have to do further testing if there is any suspicion of cancer. Okay, let's talk about dense breasts. So the younger you are, the more dense the breasts are. As you age, that density gets converted into fatty tissue. So typically, the X-rays cannot go through the density. And here's a beautiful example. So as you can see, this here, let me see if the cursor is working, it's not. So this image over here to my right shows that there's 25% density, okay? And then as it progresses on, it goes from 25 to about 50%, and then 75%, and then greater than 75%. So if you look at this image below, or excuse me, this image from here, you can see that the breast cancer shows up as what? White, right? And if you have a dense breast, look at this image over here, that's 75%. It's showing up as white. So if there is a tumor, you're not gonna see it, right? So women that, or men I should say, that have dense breasts, you have to do other imaging. You may have to do an ultrasound. You may have to do a 3D mammogram, which is also called a tomosynthesis, where they actually do a 3D view to see if there could be something there. Or you may have to do a breast MRI. So, something to keep in mind. And with the recent changes in how mammograms are reported, it is required by law actually for the radiologist to list if your breasts are dense. Why? Is because there was a lot of cases of women or men having dense breasts and it wasn't reported and people got breast cancer because you cannot see through the density. So now it's mandated by law, you have to list that this patient has dense breasts and that it needs to be worked up with further imaging. Here's an example of ultrasound. So fluid shows up as black. So this black hole here is fluid, and most likely that's just a cyst. And again, cyst is just benign. And then in the image below, again, you probably can't see, but there's a little speck of white that is actually a cancer that is forming. So this is how the ultrasound shows up. And so if there is a lump, you want to do you want to follow up with an ultrasound. And the ultrasound would tell us, is the lump solid or is it cystic? So cystic is fluid filled. Solid is not fluid filled. So if it's cystic, it shows up like this black hole. That means it's fluid, it's most likely benign, don't worry about it. But if it's solid, then it needs to be worked up with a biopsy. So now we're having further workup done. And then this is an example of the breast MRI. As you can see, this arrow over here shows a tumor, and there's all these blood vessels that are going towards the tumor. I mean, it's really amazing, subhanAllah, just to even take a look at this image. You can see the actual construct of the tumor and how it's engaging all of the blood vessels to make it grow. You know, it's kind of like a parasite, right? I mean, it's just, subhanAllah, it's really amazing how these tumors grow. So these are the imaging modalities that may have to be done after the initial mammogram, okay? Something else is a clinical breast exam, and this is something that they can do in the clinic or a self breast exam that you can do on your own. And again, we talked about the 3 different characteristics, remember? So if we feel a soft pee, what does that mean? It's most likely a milk duct. If we feel like a soft kidney bean, what can that be? A lymph node. And then if we find a lemon seed, what could that be? Cancer, right? Okay. Briefly, I'm going to talk about the breast cancer screening guidelines. Again, I don't want to pull you down with all this medical jargon, but there's different recommendations from different societies. And it's very confusing because every society has a different recommendation. So we in family medicine tend to follow the United States Task Force. It's the United States Preventative Services Task Force, and they recommend for women, not men, to do breast cancer screening with a mammogram every 2 years at the age of 50, okay, up to the age of 75. Now, the American Cancer Society says, we want to be a little bit more aggressive. And so what they recommend is every year at the age of 40. So realize that there's differences in recommendation. So this is why it's important to see your doctor. They have to tailor the recommendation to the patient. They need to discuss with you the risks versus benefits of doing, let's say, breast cancer screening at the age of 40 versus the age of 50. If you have a higher risk factor, so if there's a family history of it, they may say, you know what, because your mother had breast cancer, we're gonna start at the age of 40. Now, if you have a patient on the flip side that's completely healthy, they say, you know what, I'd rather wait till I'm 50. That's okay as well. That's still following some of the guidelines. Doing a breast exam in the clinic, so when the physician actually goes and does a breast exam, that also can be controversial. The United States Task Force states that there's insufficient evidence that you have to do a clinical breast exam. So again, a physician actually does a breast exam, that you don't have to do it every time, and that there's insufficient evidence to state that it needs to be done. However, other organizations say otherwise. The American Cancer Society says that it should be done every year. And then same thing with your self-breast exam. The United States Task Force says that you don't need to do a clinical breast exam every year. And the reason they came up with this recommendation is because they were worried about overdiagnosis. So what ends up happening is, if a woman or even a male is doing a breast exam, let's say every month, and they find something, they're gonna be really concerned. They're gonna rush to their doctor, which they should, don't get me wrong. And majority of the cases, it's going to be benign. majority of the cases will be benign. However, what ended up happening? You had to go to the doctor, you were probably very anxious, you had to get a mammogram, an ultrasound, even a potential biopsy. All of that is very anxiety provoking, and we understand that, and there's a cost to it, a cost to your insurance, of course, and even to you if it's a diagnostic test, and in this case, it would be. So it can lead to a lot of over-testing, and that's where they came up with that recommendation to not do a self-breast exam. However, again, the other societies say that you should do it if you are high risk. So again, remember those risk factors that we discussed. Okay, overall, you should be aware of your breasts and what they feel like. And so what I tell patients is, err on the side of caution. It's good to know your own body, right? So, it's better to consider doing a self-breast exam than to not, because we want you to know what is your normal and what is your abnormal. All right, and then, kind of coming towards the end, this slide is really important, and this is why we are doing this presentation today. And if you look at these numbers, so if you are diagnosed with stage 0 or stage 1 breast cancer, your 5-year survival rate is close to 100%, okay? And then as you go along, so stage 2, stage 3, stage 4. Stage 4 is metastatic breast cancer. It's now spread to your liver, it's spread, even to your brain, for example. Your chance of surviving is what? 22%. That is very low. So the whole idea is to catch you when you're in that stage 0, right? If we do screening when you have no symptoms, we can potentially find a stage 0 or a stage 1 breast cancer that has 100% survival rate. That is amazing. That is so amazing. But if we ignore it, and it starts to grow and starts to spread, now you're a stage 3 and 4, and now you present with a lump or a dimple, or some skin thickening or nipple discharge. Now you go to the doctor. What are they gonna say? They're gonna say, I'm sorry, but you're already a stage 4. Your chance of survival is now 22%. If we had caught this earlier, you would have been, your chance of survival would be 100%. So this is the essence of screening. We have to screen when you have no symptoms to prevent disease, to prevent sickness, and to prolong life. So, that's pretty much what I wanted to talk to you all today. Really understand, why this is important, what we can do to prevent cancer, how we are screening, and it's important to know your lemons, right? Know your lemons. So, and I can entertain any questions if you have any.
إن الله وملائكته يصلون على النبي